My interprofessional collaboration project is centered around the patient I encountered during my preceptorship in the ICU at the Providence St. Mary Medical Center in Walla Walla. The patient is a 72-year-old male with a full coat. He was admitted to the ER on February 17th at 5:30 a.m. due to acute respiratory failure. This was accompanied by hypoxia and hypercapnia. His medical history includes heart failure with preserved ejection fraction, COPD, hypertension, stage 3 chronic kidney disease, type 2 diabetes mellitus, non-ischemic cardiomyopathy, and coronary artery disease. Cardiac catheterization was done 2 years ago, and this patient is divorced and was a former musician who played the guitar. He lives alone in an apartment and is generally independent in his activities of daily living. Using a standard cane for mobility, he does not drive and typically walks to the grocery store. Additionally, he is an active smoker. He identified as an atheist and has one daughter and two sons, with his daughter providing a reliable and expedient assistance as needed. Upon arrival in the ER by ambulance, an arterial blood gas ABG test was conducted. The results showed a pH of 7.09, PaCO2 of 81 millimeter of mercury, a BNP level of 1,155, and an oxygen level of 70%. These findings indicated severe acidosis, severe hypercapnia, and severe heart failure. Initial treatment included administering bronchodilator, continuous CPAP, and steroids via IV. Additionally, 100 milligrams of ketamine and 100 milligrams of succinylcholine were given. However, these interventions were ineffective, and the patient continued to struggle for a breath. As a result, that patient was endotracheally intubated and placed on mechanical ventilation. He was then transferred to the ICU where I first met him. The physician ordered patient restraints to prevent him from pulling at the endotracheal tube. I would like to share details about the healthcare team we collaborated with for this patient. The respiratory therapist had played a crucial role since the patient was intubated. They regularly assessed ABG levels and adjusted setting to maintain safe O2 and CO2 levels. Key responsibilities included monitoring peak airway pressure to prevent ventilator-induced lung injury, administering humidification therapy to prevent airway dryness, evaluating the patient's ability to breathe independently through spontaneous breathing trial, SBT, preventing ventilator-associated pneumonia. I administered medications such as carvedilol and Jardiance via an orogastric tube and checked blood glucose level regularly. Also, Lasix, methylprodazole, and Protonix were administered via IV push. Oral care was performed every 2 hours in accordance with facility policy protocol. The patient was sedated with midazolam and fentanyl via IV. During a spontaneous breathing trial conducted by the respiratory therapist, my preceptor had to pause the control substance because these medications can depress respiratory drive and interfere with accurately assessing the patient's ability to breathe independently. As the respiratory therapist provided care to the patient, I focused on observing physical signs such as vital signs, skin color, facial expressions, nonverbal cues, and used gentle touch and soft tone of voice. The patient was extubated on the same day he was intubated during my shift. The patient's SpO2 was 97%, heart rate was 92, and her breath sounds were diminished. He passed a spontaneous breathing trial SPT passed the bedside swallow test, and his pH level was 7.356, and his PCO2 level was 46.8 millimeter mercury. The patient had a good tight stimulation and a non-productive cough. My preceptor called that patient's daughter regarding his situation, and she felt relieved to know that he was extubated and conditions were stable. Collaboration between respiratory therapy and other healthcare teams are crucial for successfully weaning patients off ventilators. Mechanical ventilation can save lives. However, using it for a long time can lead to more patient health complications. Longer hospital stays and increased time in ICUs, it can also cause mental health issues. Research shows that many patients who spend time in the ICU and need mechanical ventilation may develop PTSD. A study from Hopkins Medicine 2013 and Supported in Stuff 2023 found that 1 in 3 survivors showed significant PTSD symptoms that could last for up to 2 years. 3 years. The team did a really great job for the patient to be extubated within a very short period of time. Another important healthcare team member was the palliative care team, which included palliative RNs and advanced practice clinicians. That team's primary goal is to attain patient acceptable quality of life care through the trial of medically effective means. The palliative care team visited the patient and discussed what brought him to the hospital, and education was provided on chronicity and the progression of the disease. The palliative care team also discussed with his current code status and expressed concerns related to the patient's advanced disease state. They discussed hospice in an introductory manner, including what services are provided. The patient said his independence was so important and he did not want to have many people in his apartment. And he is considering the option of hospice, but likely wants to be discharged home. The team discovered that the patient did not have important legal and medical documents related to end-of-life care and medical decision making. So they began to education regarding advanced directives, and the patient was amenable to completing the form. He named his daughter as the primary surrogate medical decision maker. The patient was considering a change to his court status, but he said he would like to discuss it with his daughter and sons before making that decision. I understand the difficulty of and how tough it is to have these conversations with patients in these circumstances for both myself and for the patient. I thought it would be perfectly normal for him to feel uncertain or emotional. However, the patient was calm as if he had realized his fate. The patient seemed to understand that intervention of the palliative care team helped him explore his current options, plan for his future care, and ensure that his values and preferences remains central to his decision-making process. After the discussion between the palliative team and the patient, all I could do was sit quietly beside him, fully present, and listen to his words. It was a difficult moment, and I was not fully sure how I could support him, but I just wanted to ensure that he felt comfortable and at ease. And the research in ITO 2022 shows that palliative care team can improve patient outcomes. Palliative care is a team approach that improves the physical, emotional, and spiritual well-being of patients and their families facing serious illnesses. And in 2021, studies highlighted its importance in the ICU to relieve symptoms, set patient-centered goals, and provide end-of-life care support. what I gained and learned from these collaborations. One, enhanced empathy and focus on patient-centered care. Working with the teams deepened my understanding of the patient's lived experience. I observed that when all team members, whether addressing acute respiratory issue or discussing long-term quality of life concerns, focus on empathy, the care provided becomes more holistic and centered on the patient's needs. Number two, acknowledgement of the importance of role clarity. Collaborating with professionals from various disciplines has underscored the unique contributions each individual makes to patient care. Clear role definitions enhance teamwork, minimize redundancy, and ensure that every aspect of a patient's condition is addressed effectively. Number three, utilizing technology for effective communication. That experience highlighted the advantage of using digital tools for real-time information sharing, whether it's through electronic medical records or secure measuring messaging platforms. Technology greatly enhances communication, ensuring that all team members have access to the most current patient information. That three recommendations for quality improvement I can think of now. One, improve communication skills not only for the patient in end of life, but the family. Develop ongoing training programs and new staff to improve skills in discussing end of life issues and providing comfort care focused on understanding feelings, listening attentively, and respecting cultural differences. This process involves patient family members, caregivers, and health professionals, and can become complicated. Understanding the best way to communicate during this time is crucial for improving care quality. In Kentish Barnes 2023 studies show that communication between ICU staff and families is very important. This communication affects how families feel in the month after a patient's death. Families who find that communication poor are more likely to struggle after their loved one leaves the ICU. Number two, getting feedback from patients and families. To improve care quality and teamwork, we need a clear way to regularly gather feedback from patients and their families. This will help us identify areas that need improvement and create solutions that meet their needs. That research in Barger 2022 shows that when patients have the positive experience, it leads to better safety and effectiveness in cares. By using the approach, we can make sure our service meet patient needs, leading to safer and more effective care. Number three, to promote staff well-being and stress management. Working in ICU is challenging for healthcare professionals who care for critically ill patients and their families. High stress and conflicts among team members can harm staff well-being and affect patient safety. Rodriguez writes 2024, to support these professionals, we should provide stress management training, mental health support, and relaxation programs, improving communication skills, and practicing mindfulness can help ICU staff cope better. By prioritizing these measures, we can create healthier workplace and provide better patient care.